So PSC and research. So this is taken from the questionnaire and the survey that was conducted through PSC support. I think they're all fantastic questions, and I wish I was able to answer them. But that encapsulates the issues around PSC, the unknowns. It's the old Rumsfeld unknown unknowns and known unknowns and all the rest of it. In terms of how active is research in PSC, well, this is just a summary of the number of papers that are published annually in medical literature where PSC is cited as, within the article or within the title or whatever. So you can see it looks, effectively, the number of publications has risen from less than 200 a year to over 300. So that's over, about a 30, well, I can't do the maths, but about a 50% increase in the amount of publications that are. So there is work going on, but the problem is it's not really answering the questions. So I think to kind of simplify the unanswered questions, I think the things that we think about, and I think you think about, and we all think about, is PSC a single disease? There's lots of different types of patients who have got PSC, and there's a lot of different conditions that people with PSC have. So is all PSC the same, or are there various types of PSC that are different? And do those different types of disease have the same causes, and do they have the same trajectories? So are the outlooks different depending on the type of disease that an individual has? I don't think we know the answer. We've talked about it. Symptoms, what are the cause, what are the treatment of the symptoms, the lethargy, what do we do about it? A big issue is about how do we predict prognosis. We've talked about it. And the relevance of that is obviously for having a conversation with individual patients when we see them in clinic, but it's also relevant to how you would design a study to offer a treatment that might be effective for PSC, because how do you measure a response to the drug that you're offering if you don't actually know how to measure the progression of the disease? So, and then the final thing is that we know there aren't any good medical treatments at present, and so we need more treatments. But to get those treatments, we have to address some of the issues, and for us to develop the ideas for the new treatments, we need to kind of address some of the issues up here. And then once we've got the treatments that we want to use, we need to address some of these issues, like what are the endpoints of clinical trials going to be. So up until now, most of the research has been done in single centres with single cohorts of patients, so that one hospital has X number of patients, and then they conduct research. And there's the issue of endpoints. What endpoints are used aren't really validated, and so it's very difficult to compare one trial with another trial. And there's also the issue that there may be different. It may not be one set of. It may not be one group of patients with one disease. It may be that actually, out of the 100 patients that are in that publication, that some patients have got one type of disease and other people have got another type of disease, and the risks of developing problems may be different in each of those subgroups. So it's quite difficult to say, is a treatment working? And the other thing is that we haven't, we're now addressing it, but there hasn't been a biobank where we've got massive number of patients with samples stored on them, where we've well described the individual patients and the features of the disease within those individuals. So that's kind of what's been holding us back, I think, are those main points. So in 2009, a UK PSC consortium was set up, and that was based around undertaking a genetic study. And it's actually been quite a success. It's now open in over 200 NHS hospitals, and the database is kept in Cambridge, and there's about 2,400 patients that have been identified, and of those 2,400 patients, about 1,700 of them have actually provided a DNA sample, either as a blood sample or a sample of sputum. And I would imagine many of you in the room have have already participated. If you haven't, we'd be very happy. You can do it directly with them. I'm sure PSC support can put you in touch, or you can contact us and we can help get you involved in this cohort of patients. But there's some problems with it. It was designed to answer a specific question, which was around genetics, and so a lot of the additional clinical detail that we needed about patients wasn't gathered at the time. But it has been successful, and it has led to collaborations out with the UK. And the big international PSC consortium is, so that's International PSC Study Group, was developed in 2010. There's 17 countries that are involved. The cohort from the UK is about 2,500. The total cohort in their data set, 7,500. So we've made quite a significant contribution from the UK. And it's run from Oslo. There's a chap called Tom Carlson, but there's many, there's two or three meetings per annum where the researchers get together and try and set up collaborative studies to try and address the issues that I've outlined. So coming back to UK PSC, well, it was set up in 2009, but there's been quite a lot of success in the UK setting up rare disease consortia for other liver diseases like PBC and autoimmune hepatitis. And so there's been a reinvigorated attempt to try and develop UK PSC from pretty strong foundations that we have to a more effective national study, which would involve more detailed phenotyping, just means characterization of the patients, and biobanking, so that we're not just taking one sample of cells, but we're taking blood, storing blood samples, maybe urine samples, maybe even feces, and other samples, maybe when patients have ERCPs or colonoscopies. And the plan for this iteration of UK PSC, and this has just been submitted as a proposal to NIHR, which is a big funder of health research, at the end of October, is to try and improve the basic understanding of the disease. As I mentioned, the endpoints of trials, so what can we use instead of death or transplantation? What can we use that would involve following up patients for a lot shorter period of time, that we could know whether a treatment was working, but we wouldn't need to follow people for an average of 15 or 20 years to know if it's actually worked, because clinical trials like that are just impossible to conduct. Trying to break the disease down and try and understand if there are different types of disease, and if each of those different types of disease are different, have got a different cause or mechanism by which they've developed. And in organising this whole kind of construct, it will provide the perfect infrastructure for us to offer interventional clinical trials for very well evaluated groups of PSC patients, so that we can really access clinical trials early for patients with PSC in the UK, and we can provide very good answers as to whether these treatments are effective. So that's the sort of rationale behind the submission that's just gone in last month. And so the plan for the research proposal is to have two groups of patients. Out of those 2,500 patients that I've mentioned, trying to get very detailed information on around 1,000, and trying to recruit an additional 200 more patients than the 2,500 that have been identified so far. And that's going to be the sort of bulk of the PSC, the sort of cohort. But there's a desire to look in much greater depth into subgroups of patients to see if we can distinguish a difference in the PSC that some patients have from the so-called classical PSC associated with ulcerative colitis. So the particular groups of patients that are being looked at are those that are diagnosed young, because there's a suspicion that patients who present in childhood or in early adulthood have a much more inflammatory type of PSC. So we often see patients who've been diagnosed with what was thought to be autoimmune hepatitis and then evolves into PSC. So the question is that a different disease? The second is there about 15% of patients say will develop some form of malignancy, predominantly cholangiocarcinoma. But is there a genetic component in developing hepatobiliary and other malignancies in patients with PSC? So there's a subgroup of 50 patients with who've developed cancer or have demonstrated to be at higher risk of developing cancer that will be looked at. There's this group of patients that Steve talked about with small duct PSC. So classically, PSC affects the intra and extrahepatic bile ducts, so the bile ducts within the liver and outside the liver. But there's this subgroup of patients that it affects only within the liver that are thought to have a better prognosis. Now, some people believe that that's just an early stage of extrahepatic PSC, but others believe, and it may well be the case, that this is a different disease. And what can we understand about PSC by looking at the people that only have it in the liver versus people that have it in the classical form inside and outside the liver? And then we know that about 20% of patients with PSC will not have inflammatory bowel disease. So are the people that don't have inflammatory bowel disease the same as, and PSC, the same as people that have PSC and inflammatory bowel disease? And then the final group that's been of interest, quite a lot of interest recently, is Steve talked about IgG4 disease, where in patients that don't have PSC, and that's a disease that's very responsive to immunosuppression, but increasingly within patients with PSC, it's recognized that some patients have high IgG4 levels, and it seems to be associated with a worse prognosis. And so that group of patients need to be studied in a lot greater detail. So they're going to, a cohort of 50 patients with elevated IgG4s will be looked at compared to a larger cohort of patients with classical PSC. So that's the sort of research plan over the next 3 years if this is funded. And there'll be, in the way that I've described, there's 200 plus centres that are open and recruiting patients to the PSC, UK PSC. There'll continue to be that arrangement where there'll be national recruitment across many NHS organisations, but there'll be research hubs, and there'll be about 4 or 5 of them around the country, where the much more detailed assessment of patients will take place, involving both laboratory and clinical evaluation. So that would be using some of the technology that you've seen at the back of the room, the machines that we've got to better assess the stiffness of the liver and how much fibrosis there is in the liver. And the idea is that in certain centres we'll be able to look in more detail. And the idea is to produce this platform which will allow us to do better research, answer some of the questions that I mentioned before, but also allow patients with PSC in the UK to get very early access to new treatments as they become available. So in terms of the main research hubs, Gideon Hirschfield in Birmingham is the one that's coordinating our efforts. But Newcastle, Cambridge, ourselves and Oxford are likely to be the hubs. There may be 1 or 2 others, but so they're distributed sort of east, south and north across England anyway. And in terms of the research that's going on, and so we'll be very active participants of that, but in terms of the other research that we're doing at They're All Free, we've got collaborations with both the International PSC Group and with UK PSC. And as you can see, that these are real international efforts. These are the countries that these projects are being led out of, and we're collaborating with all of these. UK PSC, we talked about the genetic study, the new 2014 version of UK PSC, the submission to NIHR. The 2 areas that we see that we can make a particular contribution to understanding is non-invasive, we've talked about already, is non-invasive assessment of liver disease, and trying to establish the disease severity, but also trying to individualize prognosis for patients. And then also the issue of cancer risk, because that's clearly a big area of interest of Steve's, but we've and he's got a very active research program in patients with biliary tract cancer, but we're very interested in trying to better detect risk and development of biliary tract cancer in patients with primary sclerosing cholangitis. So those are the collaborations we've got. We've also got a number of studies that come under each of these headings. So that's the PSC fibrosis and stratification work that I've talked about. That's some of the equipment that we've shown at the back of the room. And then PSC and bile duct cancer. And one of the things that we're hoping to develop is this trial using the kind of endomicroscopy that Steve mentioned, where we will, when we're doing ERCP, we'll not just put scopes into the bile duct, but we'll then use this microscope within the bile duct scope to look at the lining of the bile duct to try and earlier detect those patients that are at risk of cancer or are developing cancer. And all of these studies are run through our dedicated autoimmune clinic, which is run on a Monday, autoimmune and PSC clinic that we run on a Monday afternoon, where we have access to all these technologies as we're at the same time as we're seeing the patients and doing the routine clinical care. We're biobanking from the from patients who consent to be involved and undertaking these more detailed evaluations using the equipment that you've seen. So the group that are involved are many of the fellows that are involved in the projects were here earlier on. I hope you had the chance to speak to them. I think many of them are still here, and I'm sure would be happy to have a word with you at the end of the meeting. And then Aileen, who unfortunately isn't able to make it, Steve, Massimo, and myself are the ones that are the kind of leads for the projects within. They're all free. And then we've got a number of PhD students working with us as well. So in terms of clinical trials and new treatments, there are several. I don't know if any of you are involved in any of them at the moment. There's not much that's open right at the moment. I think this study may be closed now. I think it was open through Birmingham, Oxford, and Norwich. This is a new treatment for the treatment, so a new drug being looked at for the treatment of itch. The study for patients with PBC just closed yesterday. The PSC study is being looked at, is being undertaken in the US. We don't have any results of it at the moment to know if this is an effective new treatment for itch in patients with cholestatic liver disease, including PSC. There's this antibody which has already been evaluated in patients with ulcerative colitis, and it seems to be an effective treatment in controlling ulcerative colitis. But there's some theoretical mechanisms by which it could be an effective treatment in PSC, and there is now a randomized control trial taking place, which will probably be open in 2 or 3 of the hubs that I've mentioned. So I think ourselves, Birmingham, and maybe Cambridge will be taking part. And the aim is to try and use this to see if it will reduce the amount of inflammation in the liver. There's another treatment which is an antibody treatment. So these MABs are monoclonal antibodies. So these are given intravenously. And it's an antifibrotic agent which is being used looked at in a number of diseases, non-alcoholic fatty liver disease being one example. But there's a study which I think is just closed as well for PSC. And that's a study that's been, again, we've been recruiting to Birmingham. I'm not sure what other centres have been involved. And then this new treatment here from Intercept Pharma called the beta-cholic acid, which is a new bile acid with an FXR agonist function, which has been looked at in a phase 2 study in primary biliary cirrhosis. And has shown some very promising results. There is a phase 3 PBC study that will be starting probably early in 2015, and Intercept are simultaneously conducting a study, phase 2/3 study in in PSC patients, and that will be opening in the UK as well. All of these studies that I'm describing are, we call randomized controlled trials. I'm sure you understand that, but just to be clear, that when we are treating patients in these studies, we don't know if they're on active drug or placebo. And the idea is at the end of the study, once the study is completed, you can then unblind the data and see if the people that have been on treatment have had a better outcome than those patients who were on the placebo. So they're not at the stage where we are, these are treatments that we can offer into the clinic. Several of the studies, once they're completed, there will likely be an extension arm where patients will be allowed to continue on with the treatment if they so desire. And by that time, there should be reasonable evidence whether if the treatment is effective. So people that are involved in the studies will potentially have earlier access. But it's just to make the point that these treatments are not the sort of treatments that you can be going to speak to your doctor about tomorrow and expect that they'll be able to offer you something different. But it's really just to make the point that the work is being done, that there is hope there that these treatments will become available, but realistically it's going to take a few years before we're clear if these are significant advances in the management of PSC. So I think in summary, as you all know, I don't need to tell you, there's a large unmet need in terms of research for primary sclerosing cholangitis. There are these large consortia being developed, and I think UK have really been in the forefront of that. So I think you know, more than 200 hospitals have been collaborating on PSC, but it comes back to the point that Massimo was making, which is you need funding to support the work, and it's increasingly difficult to find funding. But we're optimistic that the submission that's gone in October will be successful and allow us to kind of prime some of the work that I've described. And the important thing is that we can pool the expertise, the data on the patients, and also material on patients for us to do really excellent collaborative research, both within the UK and internationally. Just to highlight that there'll be several UK PSC hubs, ourselves, Birmingham, Cambridge and Oxford. It's likely that there'll be others in the north like Newcastle. There may be others in the south as well, but these are certainly centres that will be central to the organisation of UK PSC, as well as PSC support, because Martine's involved in the governance, the governing sort of board, management board for the UK PSC project, and that finally that clinical trials are in evolution, they are ongoing, but the reality is that they're only likely to be open in a few centres within the UK, and if you are wanting to access clinical trials and participate in clinical trials, and it does seem that many of you are, then it will be about trying to make contact with one of the hub centres, and there's various ways that can be done, maybe going through PSC support, and Martine could contact us asking for a referral from your gastroenterologist or from your GP to one of the centres is the alternative. But I hope you get the impression that there's a lot of, we're very highly motivated to try and address some of the major issues and deficiencies in our knowledge and our treatments of your disease. Thank you.